Terumo Neuro. We'd also like to thank W.L. Gore and Associates for their in-kind product support of this event. And lastly, we'd like to thank the following companies for their exhibit support of this program. We encourage you to visit their booths throughout the day in the lunch lobby area. Gold level sponsors are Medtronic, Vascular, and Penumbra Inc. Silver level sponsors are Balt, Catalyst Pharmaceuticals, Terumo Neuro, Pfizer, Phenox, Stryker Vascular, and W.L. Gore and Associates. Please visit the online syllabus for additional course information. There you can find the agenda, industry acknowledgements, faculty information, and PDFs of presentations that we were able to share. Please see the CME staff at the registration desk if you have any questions. For evaluation CME credits, for participants tomorrow, you will receive an email with instructions, excuse me, on how to claim credit for this course and complete the course evaluation. Process must be completed in one sitting, so you can wait. So please wait until the conference is over in order to complete that process. We appreciate your feedback. If you are only attending the Grand Rounds lecture this morning, please follow the normal process at the end of the lecture to claim credit. Symposium registrants, please do not use that process, just use the one for tomorrow. Faculty disclosures can be found here as well as in our online syllabus. I'll declare any disclosures at the beginning of the introduction. After the keynote, there will be a brief 1 to 2 minute transition period for virtual attendees to switch from the SSF Neurology Grand Rounds Zoom session to the rest of the CV Symposium Zoom session, which is a separate link. If you need assistance, please contact us at cme@swedish.org. Thank you for your assistance. All right, without further ado, I think we'll try to stay on time as much as possible. It is my pleasure to announce the SSF Neurology Grand Rounds and the William Likoski, MD, Endowed Lectureship keynote speaker, Amytis Towfighi. She's going to be talking, her title is Interventions to Address Inequities on Vascular Risk Factor Control. Dr. Towfighi is a professor of neurology, a clinical scholar, and associate chair of the neurology department at the Keck School of Medicine at USC. She's the founding director of the Southern California Healthcare Delivery Science Center, director of neurologic services at the LA County Department of Health Services, and medical director of research and chief of neurology at LA General Medical Center. She trained at MIT, Johns Hopkins, where she got her MD, Massachusetts General Hospital, where she did her internship, and then she went straight on to be at the Brigham for her neurology residency. And then where she met me, we were both at UCLA, where she did her stroke fellowship. Her research focuses on equities in cardiovascular care and outcomes. She has led several studies of team-based interventions to improve vascular risk factor control in historically marginalized populations. She received the American Heart Association Robert Siekert New Investigator in Stroke Award and American Academy of Neurology Michael Pessin Stroke Leadership Prize. She has led AHA scientific statements and guidelines writing groups, including chair of the Strategies to Reduce Racial and Ethnic Inequities in Stroke Preparedness, Care Recovery, and Risk Factor Control, as well as Post-Stroke Depression scientific statements, and she is the vice chair of the Secondary Stroke Prevention Guidelines. She led the Social Determinants of Health Working Group of the National Advisory Neurologic Disorders and Stroke Council. That is a mouthful, but most importantly, I have known her for many, many years now, and she is a good friend, and just I admire her scientific career. She's done great research, and she is going to lead off this special, I would say, CV Symposium, where the entire focus is going to be on women, not only just women, but women who are advancing stroke education and stroke care. So with that, no further ado, Dr. Towfighi.
Thank you, Dr. Lowe, for that introduction. It's my pleasure to speak to you all today. Thank you so much for the invitation. I have no disclosures other than funding from the NIMHD and NINDS, which has supported the research I'll talk to you about today. The learning objectives for this talk are to identify key inequities in post-stroke risk factor control and to be able to identify strategies to reduce those inequities. About a quarter of all strokes in the United States are recurrent strokes, and the overwhelming majority can be prevented through vascular risk factor control, specifically controlling blood pressure, improving diet, physical activity, and smoking cessation are key. Those factors, along with abdominal obesity, account for 4 out of 5 ischemic strokes and 9 out of 10 hemorrhagic strokes. And a modeling study showed that you can have an 80% cumulative risk reduction for recurrent vascular events if you adjust your diet, exercise, and take an aspirin, statin, and an antihypertensive. Several years ago, we did a study looking at Life Simple Sevens in individuals who had had a prior stroke in the United States. And we found that blood pressure, cholesterol, and glucose control had actually been improving. You can see those with intermediate Life Simple 7 scores improved over the course of about 10 years. Actually, almost 20 years. However, the lifestyle factors were not improving. The proportion of individuals with obesity, lack of physical activity, and poor diet increased over the years pretty significantly. And what we found is that certain groups were at higher risk for poor risk factor control. So individuals who were Black, poor, and had lower education were over 3 times more likely to have poor Life Simple 7 scores. And it's been increasingly recognized that it's really the social determinants of health that are driving the high risk amongst these populations. As some of you may know, the clinical care we provide accounts for only 20% of people's health, and the remainder are driven by social determinants of health. It's really helpful to have a conceptual model of looking at social determinants of health. And a couple of years ago, we were commissioned to create a new conceptual model for social determinants of health and neurological disease. And we developed this model based on the World Health Organization model that already existed, as well as a model created by Amy Schultz about 20 years ago, more than 20 years ago, where it really shows the mechanistic principles. So the primary drivers are structural determinants. So these include policies that have resulted in unequal distribution of wealth and education. This leads to differences in education, occupation, income, which are considered social determinants. In addition, the entire built environment and healthcare access and sociocultural environment also impact health. And these are considered intermediate determinants. Then you have the interpersonal determinants. These are the things such as people's health literacy, stroke literacy, psychosocial factors, disability. And these all lead to predisposing conditions and biological conditions which impact health equity. Prior to developing this model, we had created another model based on the Schultz model, and you can see it's very similar with fundamental, intermediate, and proximate determinants leading to poor knowledge and behaviors and poor vascular risk factor control. I just want to say the reason that's so important is because the conceptual model, A, gives you an understanding of how these things are related to each other, as well as different time points to intervene. This is a map of slavery in the United States, and the darker red on the top left are the higher proportion of individuals who were enslaved in the United States. And then the bottom right shows you stroke death rates in the United States, with darker purple being higher death rates. And you can see that over 200 years, about 200 years later, policies and policies affect the health of individuals hundreds of years later. So there's numerous strategies to reduce inequities. First is really to look at the social determinants. The second is to involve the community and key stakeholders when you're planning, implementing, and interpreting any interventions. Cultural humility is key. Cultural humility is a little bit different from cultural competency. Cultural competency assumes that you can become competent in any culture, but every individual is different. Every individual has had a different life experience and culture. And so cultural humility is just acknowledging that you may not understand where someone's coming from, and just acknowledging that every person is an opportunity to learn where they're coming from. Language and literacy sensitivity is really key. It's important to communicate in the language that the person's most comfortable with. And there's some general principles for literature sensitivity. So rather than tailoring educational materials to different educational backgrounds, the key principle is to create materials that everyone can understand. And that includes using more audiovisual multimedia rather than print, having simple messages, avoiding jargon, large print, and not relying on the internet because of the digital divide. Community health workers have been an amazing bridge between healthcare systems and the community. And the idea behind why they're so successful is that people are more likely to hear and personalize messages when they think that the person who's communicating with them understands where they're coming from, has faced similar struggles, and is not really talking down to them. So community health workers have been used in a variety of roles. They can serve as advocates, coaches, healthcare system navigators, and in different health systems and for different purposes, you'll see community health workers having different roles. They really were recognized by the Institute of Medicine as one of the most promising liaisons between the healthcare system and communities, and it's really important to use them to reduce inequities. The other important thing to think about is that there's a rich literature on behavior change. As you all know, it's incredibly hard to change habits and to change your lifestyle. And so there's several principles that are helpful and a lot of studies that have been done. It's helpful to use goal setting, so helping people develop SMART goals, goals that are specific, short-term, realistic, time-dependent. Additionally, self-monitoring is really helpful. So whether it's by an app or a log, just so people understand what they're doing. Additionally, any intervention that works on behavior change ideally should have frequent contact and prolonged contact. So rather than just 1 or 2 phone calls, to have regular check-ins. And feedback and reinforcement is really helpful. So, celebrating successes and showing understanding when people are not able to make the behavior change, and to be encouraging. Self-efficacy enhancements is really important. So self-efficacy is someone's belief in themselves to be able to make the changes that they need to make. Additionally, incentives have been shown to be helpful in substance use disorders. Contingency management is a strategy where individuals are given monetary incentives to stay in a program. So they can, for example, have monetary incentives for a negative drug screen. And some programs will even provide monetary incentives regardless of what the drug screen shows, just so to keep people engaged in it. Modeling can be helpful, as well as helping people to determine what the barriers are and how to overcome them. The importance is really helping patients understand what they can do to make a difference. It's important to acknowledge that relapses are common, and that's a normal occurrence, and just to recognize any triggers for relapses. And an interviewing technique called motivational interviewing is particularly effective because it's a patient-centered style where you ask open-ended questions and help people to really understand their own motivations for making any change. It's goal-oriented and patient-centered. And we'll talk a little bit about it later. Actually, right now. Motivational interviewing has been shown to be effective in improving blood pressure control, as well as, self-care and medication adherence. And these are the key principles. One is expressing empathy. Two is developing discrepancy. So this means helping individuals understand that what they're doing does not fit with their ideals, rolling with resistance, and supporting self-efficacy. And some of the techniques include open-ended questions, affirmations, reflective listening, and summarizing. So I'm going to talk about a few different interventions for improving risk factor control. This is the PRAISE trial, which I was not involved in, and it was in the DC area, sorry, in the New York City area, where they enrolled people with stroke or TIA and randomized them to either chronic disease self-management program workshops or usual care. And the chronic disease self-management program is a program that was developed by Kate Lorig many years ago, and is really designed on the idea that people with chronic conditions face similar concerns. These include, how do you talk to your healthcare provider? How do you manage stress and pain, medication adherence? So a lot of the common issues that anyone with a chronic condition faces. And they're typically led by someone who either has a chronic condition or has a loved one with a chronic condition, so that it's a peer-led workshop. It's one session a week for 6 weeks, and it's been shown to be effective in numerous conditions, from hypertension to diabetes to headaches. This study among stroke survivors showed that individuals who participated in this program had better blood pressure control than those who did not. And the findings were pretty impressive. I'm going to talk about a few studies that we're doing and kind of review what's worked and what hasn't worked. So all of these studies take place in Los Angeles. One of them includes other sites, and primarily in the Los Angeles County Safety Net healthcare system. So this healthcare system is the second largest in the United States. It includes 4 hospitals and 26 ambulatory care centers. The majority of our patients do not have private insurance or Medicare, so they're mostly individuals who have Medicaid or are self-pay. The majority of our patients are from minoritized populations, and less than half of them speak English at home. And our first study was called the SUSTAIN trial. And this was based on the chronic care model, which is a model that bridges the healthcare system and the community and involves the healthcare system providing self-management support, changing the way the health system is designed, providing decision support to clinicians and using a clinical informatics system that helps physicians or other care providers deliver care. And at the same time, you are educating the patient and improving self-management skills. So the patient is informed and activated, and the healthcare system is proactive. And the idea is that by tackling these as well as providing community with resources, it can lead to improved outcome. This study was also based on the health belief model. This is a behavioral model about that basically says that the likelihood that someone is going to change their behavior is based on 4 key things. The first is the perceived benefits versus the perceived barriers. The second is how likely do they think that they are to have a negative outcome if they continue their behavior. Their self-efficacy and a cue to action. So in secondary stroke prevention studies, people tend to be motivated because they have a cue to action, which is the stroke itself. So our study enrolled 400 individuals, and they were randomized to usual care or the intervention. We had created this is before everyone had electronic medical records. So we had created an electronic medical record system, which provided decision support to our providers. And our nurse practitioners met with the patients twice a year, twice over the course of the year for a clinic visit. And also they conducted 3 group clinic visits, which provided education and problem solving. And we also provided self-management support. Everyone received a blood pressure cuff and materials such as logs to track their blood pressure, as well as educational materials that were tailored. And what we found was that blood pressure improved in both the usual care and intervention arm at 1 year, with no difference between the two. But the proportion of those with an LDL less than 100 was higher in the intervention group. So when we did not meet our primary outcome, we went back to the drawing board to see what we learned from this study. And we talked to the healthcare providers, and we found that a lot of their time was spent helping patients navigate the healthcare system, which is really complicated. Additionally, helping patients with barriers such as transportation, competing needs. And they really had little time to address lifestyle. So it was really navigation and medication management for blood pressure. And also we knew that they don't really understand where patients are coming from because they're not in the community. So we wanted to involve a community component to this intervention. And the reason we wanted to do this is because numerous studies have shown that community health worker teams with other healthcare providers, such as an NP or PA or nurse case manager, are more effective than usual care for improving vascular risk factor control. And these are just a couple of studies, the COACH trial, and another study looking at individuals with diabetes. And this goes back to what I said before about community health workers being incredibly important in this type of work. So we decided, we designed the SUCCEED trial, and it's similar to the SUSTAIN trial, but it includes a few additions. So first, we had a community health worker who would do at least 3 home visits over the course of a year and would work closely with the NP or PA. We had similar educational materials. We just refined them according to community advisory board feedback. The community health worker, the APP, and a physician would do regular huddles to describe, what's going on with the patient and come up with a plan. And there were at least 3 clinic visits. Additionally, we use the chronic disease self-management program workshops in community settings. So those are the workshops that I mentioned before in the PRAISE trial. So a set of 6 workshops delivered or facilitated by our community health workers. We similarly gave them self-management tools such as blood pressure monitors, and we created an app for the community health workers, which provided them with decision support. So for every vascular risk factor, they had a set of questions to ask, and depending on the answers, they would be prompted to do different things, such as education, referrals to appropriate resources, and self-management support. So we did this for all the vascular risk factors, as well as depression, health system navigation. And we found that the community health workers are actually, again, spending a lot of time on social determinants of health. We hypothesized by improving blood pressure monitoring, medication, prescription and adherence, stroke literacy, self-efficacy, and self-management skills, we would be able to improve vascular risk factor control. And our primary outcome was, again, blood pressure. We included individuals who were at least 40 years of age, just so that it would be skewed more to people with atherosclerotic stroke. They had to have had an ischemic stroke, intracerebral hemorrhage, or TIA within the last 3 months and have hypertension. And we randomized them into a one-to-one stratification, stratified by site, language, and whether they had an ischemic or hemorrhagic stroke. And we checked outcomes at 3 months, 8 months, and 12 months. What we found was that there was no difference between intervention and usual care for blood pressure. In both arms, blood pressure improved over the course of a year. However, the things that did improve were the proportion who used the blood pressure cuff at home and communication outcomes. So how often did a medical provider spend enough time with you and explain things in a way that was easy to understand? Those were better in the intervention arm. Additionally, I'd like to point out that in the usual care arm, 70% were using a blood pressure cuff at 12 months. That's because that was part of our usual care. So we didn't want to not enhance usual care because we were doing a trial. And I really felt like that was the right thing to do. So 2/3 of our patients were enrolled from Rancho Los Amigos, where I was, and I had gotten grant funding to give everyone blood pressure cuffs. So these are the blood pressure outcomes. As you can see, no difference between the two. And then we did some further analysis to figure out what's going on. And we looked at the proportion of individuals who received the full intended intervention versus parts of the intervention. So this graph shows individuals who were randomized to the intervention arm. And what you can see is that 15% of our patients didn't receive any component. So they didn't have clinic visits, they didn't have home visits, and they didn't participate in any CDSMP workshops. And the reason for that, because we were monitoring this throughout the study, is that the community health workers and APPs couldn't even reach these patients. Then a minority of individuals received the full intervention. And so we define that as 3 clinic visits, 3 home visits, and completing the CDSMP workshop. And then the other categories received some components of the intervention. And I'd like to point one thing out. As you go from left to right with decreasing levels of involvement, you can see that the blood pressure goes higher. So what that shows is that the people who needed the intervention the most were the ones not receiving it. So they had the highest blood pressure at baseline. So this is, this was really important for us. So one, there was poor engagement in the intervention arm. We also realized that because we allowed the community health workers and APPs to tailor the intervention to individuals' preferences, some wanted to work on diabetes, others wanted to work on diet, Some wanted to work on physical activity. So the fact that they were looking at multiple risk factors decreased the effect on blood pressure. We did look at a composite outcome of cardiovascular risk, and that showed no difference. But we felt that although we were very thorough, it wasn't very focused. Additionally, we looked at how often the APPs were titrating the medications, and there was inadequate titration, as well as a concern at that time during that study of not lowering the blood pressure too fast because of concerns of worsening stroke. During the course of that trial, it became clear that that wasn't a concern. So we had more aggressive protocols after that. Additionally, as you saw, there weren't enough touches. So if you go back to the principles of behavioral change, it's important to have a lot of touches over a prolonged period of time. And finally, the care model was resource intensive. So if you think about Los Angeles County and the sheer distance between sites, the community health workers can only do one visit, at most two a day. And so it wasn't a great use of resources. It was a very expensive intervention. And so we found that even if you create this amazing program, it doesn't mean anything if people aren't going to use it. So then we looked at what are some other strategies. We wanted a strategy that's more effective at blood pressure control. And we looked at the literature, and one of the most effective strategies is using pharmacists and going to the community. So Ron Victor led the barbershop trial in Los Angeles, where they cluster randomized pharmacies to have a pharmacist, sorry, not pharmacies, they randomized barbershops to have pharmacists or not to have them. So the ones that did not have pharmacists, the barbers gave people educational materials about blood pressure. And the ones who had pharmacists, the pharmacists actually worked with the patient's PCP to prescribe and titrate medications. And what they found is that if they got the blood pressure under control within 30 days, they could maintain blood pressure control. It was an extremely effective intervention, and it shows that when something is being proposed by someone you trust, for example, your barber, it's more likely to be effective. Additionally, it showed how effective pharmacists can be in these interventions. The literature also shows that storytelling can be helpful. So there was one trial in Birmingham where they randomized people to receive an intervention versus not. And the intervention was watching videos of people tell their stories about their blood pressure and how they manage them. And they found that those who watched those videos actually had better blood pressure control. And that's the same principle as community health workers, where if you feel like the person that is telling you the information is similar to you, understands the challenges you have, you're more likely to listen to them than a provider who you don't relate to. So we created the BP Reach study. This study is ongoing right now. And we're randomizing people to a health team intervention versus usual care. Very similar patient population, but we also added individuals with a history of MI because hypertension is such an important risk factor for heart attack. And similar recruitment areas. So the 4 hospitals in the LA County Department of Health Services. And here, the team consisted of a pharmacist with a community health worker. And rather than having community health workers go to to patients' homes, they did phone calls. The reason for this was really logistics, so that they could reach more individuals and they could have more frequent contact with individuals. It removes that transportation barrier. We gave this similar self-management tools like blood pressure cuffs. We did social needs referrals. So whenever social needs come up, we refer them to the appropriate resource. And we further tailored our educational materials, and we created a set of narrative videos where people tell their stories. And so and we also help people with digital access. So the community health worker helped people get on the patient portal so they could communicate with their healthcare team and help them to access an app that had all of our educational materials and videos. And the idea was that by optimizing medication adherence, self-efficacy, health literacy, and access to care, we could improve blood pressure control. Like the other, I didn't mention this for the other studies, but we always have community action boards comprised of individuals who've had the condition. So our CABs have people who have a history of stroke, MI, or hypertension. And they review our entire study. So they review our consent forms, our materials, and they provide feedback on our materials. We adjust our materials according to their feedback. And they also participated in the narrative videos. Our coaching intervention is based on the health belief model, like our other one, as well as the sociological approach, which takes into account various community factors, and the stages of change model, which basically says you have to tailor your intervention based on someone's readiness to change. So if they're not even contemplating it, then you might focus on education about the consequences of their behavior. Or versus if they're already doing the change, then you might focus on relapse prevention and self-management support. In this study, we really are doing a laser focus on blood pressure. So any additional thing is like how it relates to blood pressure. So when we discuss diet, it's really about what do you do with your diet to reduce your blood pressure. Same thing with physical activity, but the primary focus is on taking your meds, monitoring your blood pressure. And the coaching intervention is once a month for 12 months. The health coach, who's a community health worker, will call patients and provide some education, digital engagement support, and then use motivational techniques to identify barriers that the patients are facing and create SMART goals. All the community health workers received extensive training. So they took an online course on motivational interviewing, and then we did 12 hours of group training where the coaches do role play with each other and review some suggested scripts and prompts, and then we give them feedback. And then we meet with them initially it was every week, now it's actually, no, it's still every week, just to review any barriers they're facing with their coaching calls. So I mentioned the topics. It's really focused on blood pressure control. And this is an example of some of the educational materials. We give everybody a binder. We provide them with this goal card, which started in Sustain and has been further adapted throughout the years for the different studies, with the idea that people want to kind of move towards the green. So taking their blood pressure medication every day, maintaining their blood pressure, eating at least 5 fruits and vegetables, limiting salt intake, and engaging in physical activity. Our previous versions had a lot more. This is really just these 5 factors. And then on the right-hand side, you see screenshots of our app. It's a web-based app, very simple, but it includes all of our educational materials. We also provide them with resources such as AHA's Life Essential 8. And the CABs gave us feedback on the educational materials. So they expressed that they really wanted to know what medications were for, how they worked, and what are some of the common side effects. So we created some of our own educational materials, such as this one. Sorry, it's not advancing. And these are the blood pressure handouts that we developed. When we did our evaluation of the materials that were out there, we felt that most of them were a very high literacy level. We were aiming for 5th grade. And so we had to develop our own materials. And we developed these narrative videos where people really describe their own experiences and how they manage their blood pressure. So I'm going to show you an example of one of our videos.
My name is Bonnie Santino. I had a stroke that was caused by high blood pressure, and that was 8 years ago. So I had 4 jobs at the time, and I was a single mother raising 2 sons. Well, I didn't take care of myself at all, and I didn't take time to chill out. That was how I lived my life. Prior to my stroke, my experience with healthcare providers was not good. At a certain point, I decided to go to the doctor to find out about wellness classes or whatever. And I really had a difficult time trying to access that. I know I wasn't saying the right thing, but the doctors weren't telling me the right thing to do. And so I just, frankly got really frustrated. And it wasn't until probably 6 months before my stroke that I started to consciously go to the doctor and try to find some solution for my symptoms. That started the whole process of me changing my medication. And it's in that time that I had the stroke. Nobody told me you could have a stroke. And nobody told me why that concept of having a stroke would be so impactful. But what it did was made me lose a year of my life. I really think that physicians have to look at the patients like they have information that you need, It's like you've got to bring the patients into your dealing with the problem, They're not a disinterested party, Prior to my stroke, I ate everything and anything I could get my hands on. And because I'm more conscious of my foods now and more aware of the effect that certain foods are going to have on me, I only shop around the outside of the market where it has the fresh fruits and vegetables, the meat, and so I've definitely changed the way that I eat and shop. Believe it or not, I have much less money, but I have better knowledge of what I am buying for myself. I buy a week's worth of, let's say chicken, and I make the chicken all on a Sunday afternoon, and I get the chicken in the toaster oven and I bake it, and then I slice it up and put it in 5 different containers, and I put them in the fridge. And so then each day I go out and get a container and heat it up and It's great. Medication is so important. They have these pill boxes now that you have a box and it has a morning, a noon, afternoon, nighttime for each day of the week. And in that pill box is all your pills that you'll need for that week. And it's so easy. Things are better with my doctors and physical therapists because I talk to them very openly about my stroke and about what I should be doing next and what I could be doing down the road. And so that is a very good back and forth that I didn't have before. Specifically, when I talk to my doctor, he says, when you come in, I want you to tell me what you need, what you want, and I'll tell you if you can. And I say, okay. And so I have said to him, hey, can I go to Rancho and get on a bike? And he said, yeah, why not? Try it. I started going to the stroke meetings and I started going to the gym and I started going to the adjusted yoga meetings. It opened up a whole new world for me. I go to Rancho Los Amigos twice a week, work out at the wellness center. I go and get on a bike. I ride the bicycle. And right now I just go around the parking lot behind the wellness center, but the eventuality is that I will ride on the bike trail by the ocean. And I can't wait for that to happen. I haven't ridden a bike in 20 years. I mean, I go from a wheelchair to a bicycle and I ride the bike. The life change was really hard, but I am at such a positive place now. And I am working at the Long Beach Museum of Art as a docent. So I get to go to the ocean at least once a month, usually twice a month, and go look at the art. And I do that while I'm shepherding middle school kids around the art gallery. And it's so great. I mean, just working with those little kids is wonderful. I understand that I lost some time, but my life is so great now and so full that I'm kind of bursting at the seams. I think about those times when I had 4 jobs and juggling my sons around, and it just doesn't compare to now. It's beautiful now, my life. I take it one day at a time while still remembering the time that I was in the hospital. Because I think that's important to remember that. And, you know, it's interesting because I remember a little bit more, but I have this real life that I hang on to that keeps me going. My name is
Oops, sorry. Can you see the slides? Okay. So this is just a screenshot of our BP Reach app where they can access the videos. And so we've been talking to our community health workers about some of the common challenges that the patients face. And here's a list. Oftentimes people have competing needs. They forget to check their blood pressure regularly. Um,
Hold-
often,
We can't see your slides yet.
okay, hold on.
There we go.
You can see them?
Yes.
Okay, sorry about that. A lot of our patients, when they come in with a stroke or an MI, they didn't have healthcare before. So it takes a while for them to establish Medicaid insurance, to get a primary care doctor. So we're often helping navigate during that time period where they're in transition. Because of competing needs, sometimes it's hard for them to come in for clinic appointments. And a lot of our patients don't have a strong support system. And those are the ones who have more difficulty. With regards to medication, the pharmacist really troubleshoots all the different problems. And these are just some examples of problems that people faced. So if their insurance is suspended, they can't get the meds, or if they do not. So it's in California, you have to register for Medicaid, and then you get assigned to a healthcare system. So they have to be within our healthcare system to be able to prescribe them medications. Cost is often a barrier, and the pharmacist will work on choosing medications that are low cost but effective. What's really nice about having a pharmacist work with people is that when they stop a medication due to side effects, then they can talk to their pharmacist about, well, what the side effects are, and the pharmacist can help either let them know that it'll go away or change the medications. And we found a lot of miscommunication with the pharmacy as well. So it's more than just kind of prescribing the right medication and giving them self-management support. It's really kind of tackling all of the issues as they arise. And that's what the pharmacist has time to do. They prescribe the medications and that they help with any barriers. Um, and so, we have developed a lot of approaches that we take. It's also approaches that we took before. We provide everyone with pill boxes, show them how to fill them, and watch them do it. Well, often they need resources, financial services, social determinants of health. We've had to refer people to urgent care sometimes, and help them connect with the primary care provider. So these are things that we end up doing in addition to the other protocols. And often we contact pharmacies with the patient because they may need our help in terms of communicating with the pharmacy and checking if they have refills and things like that. We provide them with several key resources, such as the social workers, social support groups, mental health resources often come up. And so that study's ongoing. We're hoping to finish it next year, hoping to keep our funding, and I really have a good feeling about this trial. I think the intervention is going to work. We are doing a similar study, but it's not a trial, and it's called, incidentally, it has the same name, REACH, but it's only for individuals with intracerebral hemorrhage, and it's sites across the country. And we're enrolling individuals who've had a hemorrhage within the last 3 months, and our aims are a little bit different in this study. We want to see how social determinants of health affect vascular contributions to cognitive impairment and dementia, also known as VCID, and recurrent stroke after ICH. We also want to see how the social determinants of health affect blood pressure control and how they affect engagement with our standardized program. So as you recall, with Succeed, we found that the engagement was pretty low. And so my hypothesis is that the ones who need the intervention the most are not getting the intervention, and it's the social determinants of health that's really preventing them from accessing the intervention. So in this program, it doesn't have the pharmacist component. It's a kind of watered down approach, mainly because we really want to see how engagement and blood pressure affect these other outcomes. So we provide them with a blood pressure cuff, educational materials. We have a text message system that just kind of reminds them to check their blood pressure. They can opt out of the text messages. And we do phone calls. In this study, we only have 6 phone calls as opposed to 12. And so this study is also ongoing. Our goal is to enroll 700 participants. We're about halfway there. And so hoping to continue that, also hoping that we'll finish it at the end of next year. And so I want to leave you with some thoughts. So I've talked a lot about these different trials for blood pressure control, focusing on these downstream things such as self-management, health literacy, lifestyle. But if you want to have the largest population impact, you really have to go back to the fundamental drivers, which are the socioeconomic drivers and the policies. And in that vein, I just want to show you the Frieden's Health Impact Pyramid, which is a very key public health pyramid, which shows that the things on the bottom of the pyramid are things that are going to have the largest population impact and require the least individual effort on people's parts. So addressing socioeconomic factors is at the bottom. Then changing the context to make individuals' default decisions healthier. So an example of that would be, making soda cans lower volumes, like smaller soda cans, so that people can't buy these giant ones, or creating walk areas to make it easier for people to go for walks, things like that. Long-lasting protective interventions are things like fluoride in the water or vaccines. And then we have the clinical interventions. And then at the top of the pyramid is the counseling and education and behavior change, which is going to have the smallest impact because you're working with a small group of people and requires the largest individual effort. So based on this, I've become a lot more interested in health policy, right? And how do we affect the things at the bottom of the pyramid so that people don't develop hypertension in the first place, and it's easier for them to control their risk factors after stroke or MI. So in summary, social determinants of health are really the key drivers. When you're thinking about an intervention, it's helpful to have a conceptual model of how your intervention works, what are the principles, and also to use behavior change theory. There have been a lot of studies, and I didn't go over all of them, but there have been a lot of studies to address risk factor control after stroke, and very few of them have been positive. And again, it's largely because you're expecting behavior change. And, we're doing these 2 studies right now, hope to have the results in a year. So I think we have a few minutes for questions. And I'd like to thank my team. I have the most amazing team of individuals working on these studies.
Thanks, Amy. That was a very enlightening talk. I think I'll start out with my questions. I didn't didn't catch the barbershop study. I don't know how I missed the barbershop study from back then. Were you involved in that?
No, I wish I could say I was, but no.
I found that interesting that it was predominantly male. So, I mean, I guess you would have to go and do hair salons, I guess, for women to show similarity. But that made me think of whether or not there's a gender effect that is differential in different socioeconomic classes. And has that been studied or understood?
That's a great question. Just a quick aside that there has been a beauty shop study done by Don Kleindorfer and other studies in different settings, such as churches. The gender effect, I guess the question is with respect to what? Behavior change or how risk factors affect stroke risk?
I think probably behavioral change comes to mind first, right? There might be either behavioral change or openness to intervention also in terms of potentially gender roles and how they may have a differential effect on somebody's openness to interact with structure.
Yeah, I think that's a really good question. I don't know of any studies that have specifically looked at that. I think you would have to have enough power to be able to look at gender differences, which would make it challenging because usually studies they're powered to check changes in blood pressure or something. So you would need a larger sample size. But I think that's really important, and just should the approach be different based on gender and the roles? And so maybe one gender prefers kind of social support interventions, and the other is fine with individual interventions. So I think it's a really important topic that needs to be further understood.
And the second question I have is, when we do studies, it's pretty routine to compare demographics early on, right? You just say gender percentages were no different between the two groups, age differences were not, but you don't really ever see social determinants of health as part of that demographic to kind of get from the get-go say, hey, these two groups are the same. So potentially we're looking at an intervention and saying, oh, this has an impact but if there is a uneven distribution from the get-go and that's an undetected effect on the overall effect, maybe we're making incomplete conclusions. So as systematically, is there anything from, let's say, NINDS or AHA that is starting to push people to start looking at that from the get-go? And if you're not even looking at that, then maybe it's not a paper that can be reviewed.
Yes, so absolutely. So there's common data elements for social determinants of health. They call at the NIH, it's called the Phoenix Toolkit. The studies are now required to include social determinants of health questions. And there are certain batteries that are, preferred over others. And that was one of our when we did our advisory task force on social determinants of health for the NIH, we recommended collecting this information in any study. Unfortunately, I didn't show you the baseline characteristics of our studies, but the things we typically check are self-reported race, ethnicity, income, family size, whether or not they live alone. In one of the studies, we're doing a very thorough analysis of social support and social networks. We never ask about documentation status, mainly because it just would make people very nervous, and they already don't really trust the healthcare system. So those are some of the common ones we check, but in our studies, we check a lot of social determinants of health, but there are some guidelines, and NIH until recently has been requiring that people collect some of these social determinants in their research.
That's good to know. Let's see if we have any questions in our audience? Yes. Come on up. There's that.
I have two questions. The first question is that a story about my family. I have two siblings have their hemorrhage stroke in early 50s and recurrent in 60s. One sadly passed away, one had profound impact. I have cousins, all female, the same age, so 40, 50, and one auntie is much older. So in your research, have you found the family history taken as important one aspect? Or have you found anything about hemorrhage stroke with female identity? On those occasions that they are not under any social disability, have great social support, great knowledge, as well as great health support.
Yes, well, it's not my research in particular, but family history can be really important. The majority of strokes are due to vascular risk factors, but you can have certain things such as collagen vascular disease, fibromuscular dysplasia, with cerebral amyloid angiopathy. So there's a lot of different things that can run in families. And so it would be just on a case-by-case basis to see if there's any findings that would suggest a genetic component. So yeah, absolutely, it's important.
And the second question is that I saw your study in Southern California, there are huge Asian population. And I just want to know whether any study show that how high percentage or how anything specific stand out that is be aware.
So my studies didn't really look at kind of the cause of stroke. I would say that 20% of our patients in our studies are of Asian descent. A lot of them typically have intracranial atherosclerotic disease. But we didn't specifically look at kind of differences in cause. I have been planning to do studies in different languages. So we've actually developed a lot of our materials in Mandarin and Korean. The challenging thing is that it just requires a lot of money to do the study in so many languages because the people delivering the intervention have to speak that language too. So we'd have to hire a lot of community health workers, and that's just been difficult, but that's a future direction that we want to take.
Thank you.
Time for probably one more question. And we have nothing in the chat. So I am going to let you go. Amy, thank you so much for the talk, and hopefully you can join us for the afternoon Q&A. I'm sure there's going to be more questions that pop up from that.
Thank you so much for having me.
Good seeing you again.
Bye.
All right, so at this point for the people joining virtually, we will switch links.